Good evening, everybody. At the outset, extend my thanks to J&J team, Mr. Nashmul, Chiranjeev. So many of them are there. So really, it is a very nice concept that I came across, which they told me about a month back. And the topic also is pretty good. So what it helped me was to actually scan my old collection of cases, which I've been recording for the last so many years, and try to pick out cases which can really help in the kind of easing out the learning curve of Phacochops, which most of the surgeons in the initial stage of their career do face. Which chop to do in which circumstances, which cases should be handled in which way. So I'll be presenting a bouquet of videos which entails all these situations, normally common situations. I'm not going into very complicated or very difficult scenarios, but I'll be dealing with day-to-day situations which all of us kind of face. So let me share my screen. Is my screen visible now?
Yes, sir, it is visible.
Okay, so the art of efficient Phacochop start to finish. So before speaking on this topic, it's very important to look into the history and to look into what actually caused the concept of Phacochop to come in. And it was actually Dr. Nagara way back in early 90s who actually conceptualized the first chopper. And he gave this idea to an engineering team in USA, based in Mexico, and the engineer was actually an Indian. His name was Ravi Nalakrishnan, and with his team, he came up with the first chopper. And I'll just share with you the video, which was created in 1993. And the concept essentially remains the same, but this is how it goes. So this is called as Nagahara chop. When I started my surgeries, I also started doing horizontal chops on Nagahara chop. Then slowly I migrated to other chops. So this is how this surgery is being done. So he was doing a stop and chop. And then this is his Nagahara chopper, which has a straight tip with a cutting edge in the side. And he's doing a stop and chop first, and then rotating the nucleus, and then dividing it. So this concept is not at all a new concept. This has been there from early 90s. Of course, it has got refined to a significant level, but Dr. Nagara was probably the first one who introduced this concept of Phacochop. So over a period of time, we have seen so many other variations that have come up, right from horizontal, vertical, combo, cross, crater, multi-level. So everybody has kind of made a name, their type of chop, and they popularized this technique. But as a beginner or as somebody who's in the entry level of surgery, probably first technique to learn would still be divide and conquer, because dividing the nucleus at any given time or whenever there is a failure of your chop, it's always important to learn this technique of divide and conquer. Next would be a stop and chop, because stop and chop will give you an idea as to how to hold the nucleus, heminuclei in your vacuum, and it will help you to convert to ultimately direct chop. So this is how it should proceed. So ultimately, what is the advantage of Phacochop? So basically, the Phacochop is useful because it gives you speed. It allows you to efficiently use the Phaco power, and ultimately it leads into less Phaco energy. So how does one proceed? So as we were discussing, start with stop and chop, practice your chopping maneuvers on the heminuclei, and then you adjust the machine parameters. It should not be vice versa, because your technique, the machine needs to adopt your technique and not vice versa. So have a person from the company in the OT and make sure that the machine parameters are adjusted to your liking, and always start with a grade 2, because it's easier to do direct chopping in these types of cases. Now, before you start, you have to import these 5 points are very important. The point number 1 is that your point of entry and the depth of phaco needle is very, very important. So when I say point of entry, it's the point of entry in the lens. So when you're doing a horizontal job, that point of entry ideally should be above the center of the nucleus, and it should be deep enough to hold the nucleus. That's very important, because most of the time shop fail because your depth of the phaco needle is not good enough. So you have to make sure that when you see the phaco tip before entering, make sure that the sleeve is slightly pulled up so that you have sufficient tip for you to engage the nucleus. Next is the foot switch control. Now, for the chop to be successful, you have to have the ability to hold the nucleus in the vacuum mode. That means in step number 2, you should have sufficient patience and control, so that when you are actually chopping, your foot should not move, because that is the key that you will achieve a successful chop. Because what happens invariably is, when I used to supervise the trainees, so I would find that they would start the chop, but by the moment they put the chopper in, the vacuum is gone. So your hold on the nucleus is gone and the chop doesn't happen. So holding it in the vacuum mode is very, very important. Angle between the chopper and the phaconeedle is important, because then dynamics, proper dynamics are set, and then you get a proper cleavage. We will see that. And of course, chopper placement and its movement. And most important is, when you're doing the chopping, your hand should be very stable, because that this is one maneuver where you cannot afford instability, because instability can give rise to problems like zonular dialysis. We have seen while doing Phacochop, people have done zonular dehiscence because of the excess force that a person has used. So stability of hand is very, very important. So, sorry. Yeah. Now, while doing the above maneuvers, we have to make sure that the anterior chamber should not collapse. So if you are doing a direct Phacochop, and if you see that there is an anterior chamber collapse, that means you should immediately wait. You should basically see your irrigation pressure, and possibly there is a blockage somewhere. So you have to make sure that before the chop is initiated, the irrigation is absolutely fine. Nucleus tilting, I was just discussing this. So when you're holding the thing and when you're chopping, the nucleus should not tilt, because if the nucleus is tilting, that your forces are not going in the right direction. And phaco energy, obviously, when you're doing maneuvers, has to be used sparingly. You don't have to use phaco energy each and every time. Most of the game is with the vacuum, actually. I think I will just reshare, because it's kind of stuck. It's visible. Give me a thing. I think my slides are stuck.
Right, sir. Right, sir. Right.
Just one second. I don't know why it's not moving. I think it's stuck. I will rejoin. Give me a couple of minutes, okay?
No issues, sir.
Sorry.
No issues. No issues. Yes.
Are my slides still visible?
Yes, sir. It is in 9th slide. Probably we just need to.
I
Just have to share the screen.
Yeah.
Should
I restart the system again? If it again gives a problem, I'll do that, because after this, most of them are videos, and they should play fully. Yes,
no, I can double click.
Yeah, let me check now. So I think it's working now.
Yes, sir. It is working.
So I'll share with you this first video, just to highlight as to what we don't want when we're doing chopping. Okay. And I will tell you that this is something that each of us will face when we are learning Phacochop. And just look at this video and try to see where we are at fault. So here you can see the surgeon is trying to do a crack, and he's holding the nucleus well, but the nucleus is kind of tilting, and the chop is not happening. So some trench was already created. Again, he's trying to enter through one of the edges of the trench, and see, again, he's not able to get the thing. So basically what is happening, the forces that are being applied by the chopper are not going in the correct direction. This is, he's probably trying a vertical chop. Now he's trying to do a horizontal chop. So you can see that at this point, again trying to engage the nucleus, and nothing is happening. Nothing is happening. The reason why nothing is happening is because it's not being held properly. The vacuum is not good enough properly, or the hold of the nucleus is not good enough. So it's kind of breaking. So this is something that we should avoid while doing chopping. So this is the time when we ultimately resort to what is called as masala technique. You kind of debulk the whole thing, and ultimately what happens is the nucleus gets when ultimately you are forced to produce the nucleus in the anterior chamber, and then take it from there by making the nucleus stand, and then do all sorts of chopping maneuver. So this is something which we would not like. So in a standard chopping technique, you would not want the nucleus to stand in the anterior chamber, because your phaco energy will disturb the endothelium. Most of the phaco will happen in anterior chamber. So this is the reason why I wanted to put up this slide, is that this is what we don't want during surgery. So let's move to then what do we want? So we want in situ chops in all cataracts and all situations. You should have sufficient number of pieces before you do a quadrant removal. That's very important because if you have just divided half the nucleus, the other half is remaining like this. It's difficult to divide the other half when you have already eaten the first half. We'll show you a video on that also. And of course, avoid zonal stress. So the most important point is whatever technique you learn, there should be consistency in it. That means you should be able to do it in all the cases. And that consistency for me actually comes with definitely horizontal chop. And before actually talk about chopping, I would like to definitely dedicate this lecture to Dr. David Chang, who actually influenced my technique way back in 2003, 2004. And this book by Dr. David Chang, that is Phacochop, Mastering Technique and Optimizing Technology and Avoiding Complication, is a masterpiece. So if anybody wants to learn Phacochop, this is the book that one should look into. Very simply elucidated, and actually this helped me a lot because I had no reference at that point, as nobody was doing Phacochop in those days, and everybody was into essentially divide and conquer in my institute, which was at that time Shankar itself. So next, this is the chopper that I use. This is basically Chang's double-ended chopper. So you can see there is a blunt end of the chopper. We use it for horizontal chopping. It has got a curve, and this curve is basically engaged on the nucleus, and you have a pointed end which runs to the nucleus bulk, and it divides the things. So we'll see this. And in India, you get it from Indo-German. I have no functions at all, but this is what I've been using for the last 15 years. So let's just a quick revision of stop and chop. So all of us are probably doing stop and chop, and essentially you create a trench. This is given to by one of my friends, and you basically create a deep trench and then divide each heminucleus into segments, and then keep emulsifying them bit by bit. So probably this is a very good technique because it is also a very successful in terms of achieving achieving the division and then slowly doing the cataract. So So let's now talk about horizontal chop. That is what I would prefer to do, and let's understand the science behind horizontal chop. So if you talk about horizontal chop, first thing is your entry and your angulation between the chopper should be at least 90 degrees for the chopper to really engage the equator of the lens. So as you can see from the figure, the chopper horizontal edge of the blunt edge of the chopper goes across the equator, and the phaco probe or phaco needle is entered superior to the center of the nucleus, and it goes well within the nucleus space. And the movement of the chopper is obviously towards the phaco probe, and you can also move the phaco probe towards the chopper. Now, this is very useful in patients who have dense cataract. You may not need it as an S2 or S3. The movement of the phaco chopper is enough, but if you have a denser cataract, then you can actually do phaco a little bit of phacoemulsification, so that the probe also moves towards the chopper. So as they come closer, you can actually separate the two heminuclei. Let's see this example in a grade 2. So here you can follow the curve of the vacuum. I'm just pausing it. So the point that I want to point out is that the vacuum should be fully achieved. And this is the full vacuum 440 that has been achieved. And only at this point, you are sliding in your chopper, and you are going to see now that my chopper slides, goes below the rhexis margin, and then slides in. And this is where it produces the chop. So you can see it's such a beautiful technique that you basically take care of the vacuum, and the nucleus remains stable, and then you can achieve your goal of dividing the nucleus into two halves. And it's a very predictable technique. Every time you want it, you will get it. So this was a nucleus thing. I'll show you a real time example, a recently recorded case. So here is this cataract, and you can see a nice hydrodelineation. And you basically go and chop the nucleus into half. And with the same movement, you create one more chop. So you have created 3 pieces, one more. So very minimal movement I am doing with the phaco, and I have already created around 5-6 pies, and now further pies I'm creating. And this is how you keep creating pies. Mind it, I have still not started emulsifying because that is not required. You create your pies, and then it's done. You just continue with your phaco emulsification and remove these pieces at your leisure. And it takes hardly any time to remove this. In fact, you don't need your second instrument. If your nucleus is kind of rotating, you can just use the Phacochop to rotate the nucleus and each quadrant easily. So let's move on to the next. Now this is a slightly harder cataract. So your harder cataract, the main thing is that your vacuum should be high enough for you to hold the nucleus comfortably. So the concept here is that your vacuum should be good. You should be able to penetrate the nucleus, and very important that the nucleus is very, very stable, because if it's an unstable nucleus, it's going to be a problem. So here we are able to achieve the crack, and luckily the crack has gone through and through. Most of the times in a denser cataract, you will see that the crack stops at half a distance, and then you continue with your chopping module. And if you see carefully, my horizontal chop end of the chopper, once I've created the main chop, I am not going beyond the equator further. So rest of the chops, I am able to do it within the rexus itself. So I really don't have to go beyond the rexus. The primary chop, definitely you have to go beyond the equator to cut it, but the rest of the pieces you can easily remove without much of a problem. So this is how you essentially remove to the quadrant removal. And now you see I've removed my Phaco chopper from here, and I'm just kind of taking out each piece one by one without much of effort, because I've created all the pieces, and it's just a matter of time that they just come out very comfortably. And if you see carefully, the actual Phaco time in this is quite less, and the actual time to remove the nucleus pieces is about 1.5 minutes, which is reasonable for a denser cataract, because you don't want to do denser cataract in a hurry. You want to do in a very controlled fashion. So next we move on to the vertical chop. Okay, in vertical chop is something that we should learn. The concept here is slightly different than the horizontal chop. Here the angulation is slightly less, but the movement is different. The movement is more of a oblique movement. So you can see this, the Phaco probe enters through the center, and the chopper enters from the mid periphery. And the direction of the movement of the chopper is oblique and downwards, whereas the needle moves obliquely and upwards. So let's see an example of this maneuver. Here we see this chop. Here you need to go much deeper compared to a horizontal chopping. So I am going and engaging the nucleus. Again, very important that the vacuum levels to your comfort. And here I am basically creating a crack. Here also, once you have created a crack, you have to basically separate, go in two opposite directions to get to heminuclei. So here we have created a clap, and then the rest of the procedure goes on as we just discussed. So with this in mind, let's see how we can tackle these commonly common cataracts, which we do get in our day-to-day practice. So first, I know that you had a soft cataract, Phacochop, but I would still give my perspective on soft cataract. And what I would say that there are some myths of soft cataract, and one of the commonest myths is that, okay, you have a soft cataract, it can be easiest to manage. And believe me, this is one of the things that is one of the hardest things to manage, especially when the pupil comes down and when you think that it is going to be the most easiest cataract to manage. And I'll show you why. And second myth is that it cannot be chopped. That means if you have a soft cataract, chopper has no role at all. So this is also a myth. And most of the times you want to prolapse it and it's able to aspirate it. So that's also another myth which we will try to dispel. So let's see the common problems that one faces with a soft cataract. So here you see a soft cataract. This is a surgeon who is trying to handle a soft cataract, and in the process he's not able to catch hold any of the edge of the soft cataract. And what happens is, which is what we commonly call is the crater formation. That means you have a huge ball of nucleus, that is a huge ball of lens matter, where you have nothing to hold. And this kind of cases, then the only thing that remains is you have to collapse it and then aspirate it. Now look at this surgery here. Let's look at the surgeon. He has created the initial trench, and now look what he's doing. He's using a very sharp chopper and trying to catch the nucleus, which the vacuum will not be able to catch, because the moment you try to chop it, it will give way. So this is another thing that one should avoid doing. So he basically shifts to stop and chop, and then he again tries to eat the heminucleus with the same technique. So this is something that one should avoid, is trying to hold the nucleus with the vacuum in this way and trying to chop. So this chopping will work in a harder cataract, but will not work in a softer cataract. So what are the principles that one should follow? You have to have an in situ crack. should have adequate pupil dilatation, especially for beginners, because soft cataracts, if the pupil is not good, you can actually, it will be a nightmare. And start low vacuum. Vacuum aspiration phaco power. Initially, you can keep it in linear mode because based on your foot pedal control, you can take a call as to how much you want. So probably chopping, soft cataract chopping is not possible. I feel it's definitely a myth, and we'll see why. Let me share with you first case. This was a patient who had a moderate dilatation, and we decided that nothing doing. This eye we should not intervene without putting hooks. So we have used iris hooks here, and we have got an adequate hydrodelineation, and we are trying to now do a horizontal job. So you can see my same movement which I had explained in my other video. A simple maneuver, and I have got a crystal clear cleavage, crystal clear division now. And then we continue with our routine technique and divide each thing into three, and then slowly take it away. So it becomes very easy once you have these pieces with you, because then handling one or two pieces or half hemi piece nuclei becomes much easier than a whole of nucleus. There's no need of, there is no issue of crater formation, and I am not actually doing any vertical chop maneuvers here. Now look at this case. This was a recently done surgery. So this gentleman has just a PSC, and we basically again went for a chop. Now I want you to appreciate one thing, is that at this point my phaco maneuver is very, very minimal. That means I'm not looking at entering into the phaco into the lens matter as deep as I was entering in NS2 or NS3. In fact, you can just stabilize it, and even a superficial entry is also fine, because you can nicely divide it. And once you've divided it, you can use this chopper to manipulate these pieces and bring them out of the bag. So a lot of times these soft cataracts don't rotate that well. So you can keep doing this division, and at one point you will see that your chopper itself will help you to bring out these things. So here I'm essentially using my the blunt end of the chopper, and I've got the nucleus piece out in the center. So without taking too much of risk, it's very easy to handle these kind of soft cataracts while you're able to divide them. So division is the key. If the primary crack you get it, these becomes easy. So I'm just dealing with the pieces with the help of chopper here. And even though the rotation was not happening, so it doesn't matter because you can manipulate it with your chopper. And this is how we deal with it. Now, this is a patient whom operated last week. So this was a retrab with phaco. So with a moderate dilatation pupil. So we had to do a trab also in this case. So I decided not to use iris hooks here. And you can see that it's a small pupil, but your chopper can still easily navigate inside the below the anterior capsular axis, and can nicely hook the equator, because everything is under your control. You hook it, and you can just you can just initiate the cracks. So I'll just show you the crack here. So here I enter and see the crack. So how beautiful the crack has come, and we are able to divide this nucleus in this small, moderate kind of a pupil in a very comfortable way, without putting too much of a pressure at any point. And then continue with the same philosophy that however the soft cataract is, I will still create a pie. Whatever pies I can create as many pies as possible, and then start your phaco multiplication. See, the phaco energy is still zero. I have hardly used any phaco energy here. So essentially everything is on vacuum. So the vacuum is what is helping me to do, because the moment you start phaco, you will basically cut through the nucleus. The hold will not come. So hold in soft cataract comes with vacuum rather than using phaco energy. So here I've done all the chops, and actually the phaco energy is just zero. And this is the time where you shift to phaco to actually removing the quadrants, and it's very easy. Once you have multiple pies, really you don't have to struggle at all. So everything comes out. It's like an automated thing. So you just have to don't worry. Everything comes out easily. So this is a softish cataract with a moderate dilatation pupil in going to go phaco. Let's move on to the next example. So this is a very, very soft cataract. Almost this was probably just a small PSC, and see now, at this point I will not even enter in the nucleus. I'm just at the point on the lens itself. I stabilized the lens, and I went with my chopper and created the cracks. So you, at times, you really don't have to enter the nucleus also. You can just create it by simple maneuver of holding the nucleus with the chopper, and you can get a crack like this. And believe me, once you get this crack, your life becomes very easy because you have your pies ready, and then it's just a matter of time that they can be just removed with the help of your blunt end of the chopper. So this is how we have done the chopping part, and how we are doing, and then just to get rid of these things. Now let's move on to the harder cataracts. So harder cataracts is always a dilemma as to how to go about it, or whether to do divide and conquer, stop injure, what to do. So the principles remain like this: that you have to reduce tachecardia as far as possible. Probably hyperpulses, if your machine doesn't have torsional or transverse ultrasound, one can use, and avoid, of course, liberal use of viscoelastics. One should not fill the anterior chamber fully with viscoelastic because there is a risk of wound burn. Avoid watertight main wound, is very important. And vacuum level of for chopping would be proportional to the cataract density. So this can be dynamic based on what you feel. If you feel that it's not good enough to stabilize your nucleus, go ahead and increase your vacuum level. And the cutting efficiency should be of prime importance. It can be torsional, transverse, whatever the ultrasound delivery system you have, you use that. But the important thing is to get a good cutting efficiency. If you don't have these, try to take new tips while working. Now let's see this brown cataract. So brown cataract, again, it's a myth whether we can do a horizontal chop, because proponents of horizontal chop say that you should just don't go beyond NS3. But here you can see a brown cataract, and the same principle I've applied there. But here I'm moving my phaco probe also, because that helps in creating the division very easily and see the thing. And but we are not aiming for a through and through division. What is important in brown cataract is that these pies should be created in situ, because if you don't create these pies, the later on it's very difficult to handle a very large piece in the eye. So remember that your aim is not to really have absolute division between the pies also, because these pies will be having some inter lens connections or fibers which are actually difficult to separate. So we are not worried about that. We are only main thing is the main body should be separated. And here we are trying to have the first piece, and then the second piece we have separated. Here we use horizontal chop to kind of go through the equator and cut it. So this was an example where you can use horizontal chop in these situations because it becomes easier. So you can see that once I made the pie, even if it is not separated completely, it doesn't matter, because these pieces will come slowly into your probe. And of course, in between, you have to keep putting viscoelastic so that your endothelium has to be protected. And this is how you kind of remove all these pieces one by one. And so we are done with this thing, and I'll move on to a black cataract. So see the black cataract. So you can see this black cataract, and here also we can do a direct chop with the help of horizontal chopping. And I can show you here. The main concept is that I go as deep as possible with the phaco needle, and once it is stabilized, then only make the movement of the chopper. So here you can see that the crack has happened, but probably it's only 1/4 of the crack. So I'm not worried about that, because I know that when I'm rotating the nucleus, I will achieve the other part. So here I am separating the pies now. So once you have had the main thing, the pies separate. It's not very difficult to separate them. So from the other side, now we have created we have completed that division. And so here we are handling each pies slowly and steadily. So you can see that these pies are still connected, but we are not worried about these connections, because to separate too thoroughly is a lot of force is required. So it's not required. So when you're doing a phaco, they will get automatically separated. So once you do this, a central one endonucleus will come out. So that's an indication that the majority of the thing has got debulked, and then you can start doing your phacoemulsification. So each nucleus piece can slowly be then tackled. So here I'm tackling the nuclei pieces, and ultimately it works absolutely fine with a good anterior chamber depth and good anterior chamber maintenance. These cases are also not that difficult. Only thing is you have to have patience while dealing with these cases, because this will definitely take more time than your standard fix. So time is very important, and doing things in a very regulated manner would be the key in in dealing with these type of cataract. So let's move on to this combination method. So one can also do what is called as initial trench followed by a horizontal chop. So basically, idea is to debulk the nucleus as much as possible in the center, and then hold the nucleus with vacuum because it gives a better hold, and there is a higher chance that you will get a complete crack in this scenario. So if you see carefully, my force with the left hand is at multiple levels, starting from superficial to going to the deep depth, and this helps in basically getting the separation done. So again, you can see I'm going quite deep with my chopper to separate this, and here also if you see I'm just inducing the crack from the mid periphery. I'm not going around the equator, but in these cases one can go around the equator also if you can see equator very well. And this how first half has been done, and then you can separate this from the thing. So almost we have achieved the cleavage, and once this is done, your work is almost over. So I'm not going to the case detail, but I'm just showing you that it becomes very easy once you have done this this technique also. So somebody who's starting with the thing, it's a good idea to do a trench and then do a chopping. So this is a trench with a vertical chop. So similar concept. I'll just quickly show you this. So I have created the trench, and I'm using a sharp chopper to get the thing. The only thing with the vertical chop is that sometimes the nucleus becomes a little unstable because the forces kind of don't work in that unison way, and the control is not that much like what you have with the horizontal chop. So here also we are able to do it. It's not a problem at all, but your vacuum here is the key. You have to have a very good vacuum hold. So this is how you basically do the thing, and remaining things remain the same. So again, a black cataract where you use a combination of trench and the horizontal chop. I will not go into details of this thing, but the concept is the same. You basically create a trench and then negotiate each. Another concept that we advise is whenever you have dense cataract, and when you think that the pie is not getting separated from the nucleus, so you keep creating the pies, and what you need to do is you need to then start emulsifying from the top. What will happen is you will eat almost 75% of your pie, and a limited attachment will still remain to the main body. It doesn't matter. You eat up all the pies in this way, so the end will be a very small piece which will remain, which will have all the parts of each pie attached centrally. And that can be taken care at the end, or one can also use your own chopper to actually transact this attachment. So whichever way is possible. So the point is, once you've created the pie, it becomes easy because you can emulsify from the top. Just to share you with an example. So this is a case where it's an extremely dense cataract, and we are finding it very difficult to separate the thing, but we are not worried. We have created enough pies, and once it creates, we start emulsifying one by one. And you can see here. So this pie is being created, and if you see that it's not getting separated from the base. So this is something which is very common. So now see, I'm just transacting the upper part of the pie. So at least I have debugged the pie almost by 70%. So what will remain is the remaining 20%, which I can take care in one go. Here I am kind of trying to cut it from the base itself with the help of chopper. So this also can be done. So what happens is slowly and steadily you are essentially debulking the nucleus when the separation is not happening in the way you would want it to happen. So no problem. Do the separation slowly and steadily, and keep eating the pie. Whatever is easily emulsifiable, you keep emulsifying it. So at a point you will reach that there's a small piece that is remaining at the end, and that can be easily managed. So this is a point that I wanted to support. And this one very important point about in situ thing. So this was a patient who operated last week. He continued with this cataract for almost 2 years, and he came to me with this. So it was a dense cataract. So we did employ a horizontal trench with a horizontal chop, and we started dealing with each heminuclei as we routinely do. So here we are using the sharp chopper to create the pies, and we have done that. And we unfortunately, instead of doing the other side, I basically ate up these 3 pieces. Now the problem is that I have a huge piece heminucleus that is left, which is undivided. So that is where the problem comes. So if you have not done in situ, see this heminucleus, it has not been divided. So you see now how it becomes difficult to divide this when there is no those support on the other side. So it's like hanging a half nucleus and you're trying to chop this. So this becomes a little messy. So the advice is that whatever it is, you have to do in situ chop. So sometimes in a NS2 and NS3, the nucleus also pops out with your hydrodissection. So you make sure you push the nucleus back and do your in situ chops. That's very important because then it becomes easy for you to handle them. Total cataracts. Moving on to total cataracts, it's like a Pandora box. I think we have another 5-7 minutes. Can I continue?
Yes, sir. Yes, sir. You can continue. Yes. Sir.
Yeah. So I'm coming to the end. Few more scenarios, and then we can take up a discussion. Okay. So total cataract is like a Pandora box. So we all know that something is difficult, especially if you have a hypermature cataract. And what is important is when you do a first chop, how the first chop comes out will decide your strategy, because then you understand that how hard is the cataract. Suppose the first chop is very, very difficult to achieve. That means you're dealing with a very hard cataract. So on the spot, you need to change your strategy towards the harder cataract. So let's see some cases. So this is a case. Sorry. So this is a direct chop in a total cataract. So here again, we are stabilizing the nucleus, and it's very easy to chop these cases, these kind of cataracts. Once you have done your X's, your work is actually over. And you can do chopping in these scenarios with this horizontal chopper in a very, very easy way. There's absolutely no trouble at all. And here again, the same principle applies. Do in situ chop, and sometimes you can tilt the nucleus because you can see the equator very nicely because it's a wide cataract, and you can actually cut through the nucleus. So total cataracts, you can actually practice your horizontal chopping because you can see the equator very easily. So this is a standard total cataract. We don't know how dense is the cataract. Went ahead, did the horizontal chopping. Nicely, we are able to cut it. So we know that we are not dealing with a very dense cataract. This is manageable, and we start with our routine procedure, and that's how we continue chopping. And the same method. So consistency about your technique will give you the same result irrespective of the type of cataract you are dealing with. So here again, we have achieved the whole thing, and the whole procedure probably will not take more than the cataract management will not take more than a minute. So this was just a 50-second thing. And weak zonules, obviously you can't do this thing. So sculpting, in this case, we had to use iris hooks to support the lens. And here we are again doing the direct chop, and see the ease with which I'm able to do the thing, and without disturbing the bag as such. And here I'm not rotating also with the same thing. We have created the first pie in the same angulation, and we just remove the first pie to create a little space for us to further maneuver. So the first pie is out, and now we rotate it very gently and then take care of the other part. So I'm forwarding it now just for the time constraint. So you can see this the same way, and very gently you bring it out without, and see my whole aspiration is happening only in the center. You should never aspirate or do phacochop in the periphery because there is a high chance that the subluxated lenses, the bag can come in your vacuum. So this way you can actually deal with these total cataracts. Now this patient had a corneal opacity with, again, like I told you Pandora's box. So this is a very dense cataract. We did not realize before till we actually entered with the phaco power. And here we thinking that we will just steal the nucleus and try to do a horizontal chop. We were unsuccessful. So this can happen at times. So you need to change your strategy on the spot. As I told you, the strategy has to be decided. So here we resorted to vertical chopping. So it's a dense cataract. So as I told you, in dense cataract, you have to go very slow and try to achieve just sufficient crack so that you can manipulate it later on. So the point is that you did not make a complete through initially. You keep dividing. At one point, you will see that it becomes easy for you to remove it. So don't still start emulsifying. Just keep separating the nucleus. And so we are separating the nucleus from the thing, and you can see that it has got nicely now started to separate, forwarding it a little bit. So ultimately, we were able to remove the whole nucleus slowly and steadily, and the same principles that we apply, and we were able to achieve the frame construction. Coming to subluxation cataract, again, most of the subluxation cataracts that we see in various meetings, they're all softish cataracts. So nobody talks too much about the nucleus management. But imagine this grade 2 coming for a chopping. How do you deal with this? So you have to basically, again, resort to horizontal chopping or a vertical chopping, because you cannot do a sculpting in these cases, because it's going to cause too much of a stress on the zonules. So we have done here chopping, and slowly you can see that I am using the chopper to make small pieces without doing too much of disturbance. So here your vacuum also plays a little part, and you need to manipulate the phacoprobe opening in such a way that you are able to manipulate the nucleus with your phacoprobe itself, rather than making your chopper do a lot of work. So you can see the tremulousness in the thing, and finally we were able to manage the thing. So we had to put Sion in this patient. And this patient was a unique case where you can see the zonal dialysis on the two sides, and the superior and inferior was okay. So this case, we decided to put in CTR right at the beginning of the surgery to stabilize the nucleus, and then went ahead with our standard chopping technique. And it was fairly comfortable the moment we had put in the CTR. And our standard technique really helped us to negotiate with this nucleus opacification and nucleus thing. And the surgery went on actually quite well. Ultimately, we were able to put the lens, and the surgery went on very well. So this is another case where you can see a nice inferior zonal dialysis. I just do a little fast forward. We supported the back, and you can see here again. I just show you the chopping maneuver again. So again, a very predictable technique. Comfortably, you have made the chop, and then you have made the two divisions. And see, without rotating the nucleus, I'm holding the other part, and I've got the chop done, and the first pie is out. And then you have to slowly keep rotating and taking care of the nuclear pieces without too much of rotation. So that's very important, that you don't have to rotate too much. Show you another subluxury cataract where you can see this zonal dialysis on this side. And this case also was very difficult because the cataract was grade 3 and pretty hard kind of cataract. So this technique helped us to achieve the recombination without much of a complication, and patient did well after putting the CTR. So I'll move on to probably last few videos. So corneal opacities is again another problem that sometimes we do face. This is a patient who had cataract with corneal opacity. And here you can see, because your horizontal chop involves tactile feeling of your nucleus, you can comfortably slide your chopper around the equator, feel the equator, and hold the nucleus with the vacuum. And really you can make the crack without much of a problem. So even the visibility is also not that important in this chop once you have mastered the technique. So here, with almost 50% visibility, we were able to remove the nucleus with the technique which we just discussed. And finally, we were able to put the lens. So essentially, the technique was the same. Just wanted to highlight that even in cases where you're not able to see the nucleus, you can feel the nucleus and achieve the crack. This is a patient who was a one-eyed, about 24 RK, had a central corneal opacity, and a very high myopia. So here again, the chopping was only purely on the basis of tactile sensation. And imagine this case, trying to do a sculpting and then looking for the glow for you to achieve a division. It's absolutely not possible. So it's either a vertical chop, which will be also difficult. Here, the best is a horizontal chop, because you can feel the nucleus, so you know what you are going through. So it's very easy in this scenario also. So again, the point here remains that the consistency of your method really helps you to tackle any kind of case. So this patient ultimately did well. Of course, during the surgery, a few of the RK marks did open up. So we did put a CTR in this case, and finally we were able to close the patient. And the last scenario, PPC. So PPC is again something which there is a misconception that PPC cannot be cracked because these are soft cataracts. People try to make a crater, try to aspirate it, or try to bring it to antechamber, but my technique remains the same. Whatever the nucleus, I will basically divide it, because once you divide it to heminuclei or half this thing, then it becomes very easy to tackle. So here again, I'm going to the same technique. So you can see that here I'm again not trying to enter the nucleus, I'm just trying to stabilize it, and see how beautifully the crack has come out. And the moment your crack is done, your half worry is gone, because now you're not going to struggle with that nucleus or that lens matter, because half, and the same chopper helps you to kind of dislodge the nucleus piece and bring it to your phacoprobe to kind of aspirate easily. So here we have done that, and then you tackle the other arms. So you have tackled your nucleus management in probably less than 1.5 minutes by this technique. Otherwise, you would have to depend on a lot of mix and match techniques. So this is a case I just did last week. So this was a crystal clear lens, but had a dense PPC. A 45-year-old gentleman. You can see a nice hydrodination here. Now the temptation here is to just aspirate it. But believe me, clean aspiration in these cases not very easy, because this is the whole thing is sitting in the back. So here again, just stabilize the lens. Don't have to enter the lens. You just stabilize it and just create this movement of the chopper, and you have your two pieces ready. And the moment you have two pieces ready, your life becomes very easy, because you have this first piece gone, and second piece you can use your second instrument to manipulate. So it's just, I'm not doing anything. I just bring it to the center and they're going to aspirate it. So this is how you handle PPCs also. So one technique kind of solves all your problems. So the PPC, then you can handle it. So the last case, pseudo exfoliation, a case where you don't want any rotation of the lens because the zonules are already weak. So here we just do a very slight hydrodissection, and just quickly run through this case. So the same technique, this thing, but I want you to see the way we handle the heminuclear. So I can just show you. So we have created this thing, and again, with the help of chopper, you manipulate the heminucleus. So we don't really depend on rotation of the nucleus to achieve removal of your lens. You keep the lens in the same position. You just do a little manipulation with your testing, and the whole thing is ready for you to take out. So the other half also, we brought it in the center and did a small horizontal chop there, and rotation was not required in this case. So basically, you have tackled a pseudo exfoliation case without actually rotating the nucleus. So the zonules are not affected at all. So this was my last case. So I would just sum up with the points that chopping probably is the most efficient technique for cataract removal. Learn a technique which will give you the most consistent outcome. So for me, it was horizontal chop, because I am in control, because the left hand knows where the nucleus is. So one hand ensures stability, and probably for me, it's the safest chopping technique, and horizontal chop can cover most of the types of cataract. I thank you all for your attention, and we'll be happy to answer any questions.
Thank you, sir, for this wonderful
presentation. I think it was quite.
So request you to unshare your screen, sir, so that we can see you. Now I will be requesting all the participating doctors to ask question directly to Dr. Sagar. The floor is open. Meanwhile, some questions are there in the chat box, sir. One from Dr. Aparna Divedi. So I'd be requesting Dr. Aparna to ask question directly, if possible, from your side.
Yeah. So Dr. Aparna is there. How to choose a good chopper? So
hello.
Hi, Dr. Aparna. So what has happened is, as I showed you through my different grades, different types of cataract, actually you don't really need multiple choppers. The one chopper which works in your hand is what you need for most of the techniques. Maximum you can have one vertical chopper, because sometimes the horizontal chopping does fail, which I showed you in the dense total cataract. So in that scenario, you should always have one vertical chopper ready for you to achieve in situ cracks through the vertical chopping. So in my case, I mainly use the Chang's double-ended chopper, which is available from Indo-German. It has both the types, left-handed chopping and the right-handed chopping, depending on the surgeon's choice. And it has one end has horizontal chopping, the other end has a sharp tip, which can be used for vertical chopping. And if you feel that that vertical chopping is not happening with that, there are other choppers available in the market. The concept here is, for vertical chopping, you need a little longer tip. Anything above 1.25 millimeters or 1.5 millimeters should be fine. But you have to be very careful in softer cataract while using that chopper. So it should be only in hardest of cataracts.
So could you please tell that name again from Indo-German?
Yeah, it's called as Chang's chopper. Dr. David Chang is the one who invented this. Yeah, so it is his chopper which we have been using from 2005 onwards. I think it's almost 16 years. And I'll tell you one thing, the chopper that comes, though initially it may be a little expensive, but it lasts for almost, it doesn't get varied off. Been using it, the same chopper for almost 15 years. So you take about 3-4 choppers and that serves your work for a very long time.
Okay.
Yeah, so you said that which clock hour position you make the side port and the main port. So the side port for chopping should be about 90 degrees, as I told. 90, even 100 is fine. But it should not be less than 90 degrees because the angulation is such that it will not work if you're very acutely angled. So it should be around 90 degrees because it is made like that. That the moment you enter like this, automatically the chopper will be like this. So you don't have to put an extra effort to kind of get the equator. So
I usually do my side port at 9 o'clock and at 12 o'clock according to if it is from the superior side I'm doing. So with that, I face problems when I try to go in for a direct job. I usually have to end up doing a trench and then break and then go ahead. So I don't know whether it's the angulation, but I've seen other seniors.
No. It's not the angulation. Yeah, you're right. 3 and 12 is fine. So probably the chopper that you're using, you need to check that. So which angle it works the best. So you need to see it under the microscope. The ones which I showed works best with 1900 degrees. No problem at all.
Okay, sir.
Yeah.
Thank you, Dr. Aparna. Thank you, sir. So one more question from Dr. Arita. So I'd be requesting Dr. Arita to ask question, if possible.
Hello, sir. Sir, good evening, sir.
Good evening.
Sir, actually, I am doing stop and chop technique. But while, sir, I am making the 2 quadrant, it's okay. But then I usually do the horizontal chop and bring the 1/2 into the AC. And then while it is gradually the pupil becomes smaller and the AC surge is there, sir, very much surge. Sir, why this is? What is my fault, sir, actually?
Yeah, so as I told in the beginning that one of the essential parameters of doing chopping is that your AC should not collapse. If your AC is collapsing, you are inviting pupillary constriction. You are inviting sudden collapse of the anterior chamber, means you are going to touch the cornea.
Yeah,
so
yes,
the problem is not your technique, problem is your machine parameters. So your irrigation flow has to increase, your vacuum settings have to go down, your aspiration flow rate has to come down. Now, very important tip that we follow even with the best of machines is that when we enter the anterior chamber, before actually starting our phaco, we look at the irrigation flow rate. So whatever the machine is showing on the screen, whether it is matching with what is coming from the phaco is very important tip that one should take. Because we believe on the screen, but there is sometimes fluid constriction in somewhere, and that's where you end up with a surge. So this can happen with any machine. Actually, there's nothing great about this. This is a very common scenario. You should always check it before entry. So do a little bit of irrigation outside when you're going to do that. And if you're getting a surge, please increase your bottle height, increase your IOP if you're working on Centurion, and reduce your vacuum. And yes, and doing surgery in the anterior chamber, the idea of chopping is, the concept is this, that you have to do it in the back, because the moment you do it in the back, the chances of you damaging the nucleus or the cornea
and
gets
endothelium
to the great extent. So your endeavor or your aim should be that your learning curve should continue till the point you are able to chop all the pieces in situ. So the idea of my presentation, as I showed you, the moment you achieve those 7-8 cracks in situ, then you don't need a second instrument also. Your machine will do the rest. You just have to keep your phaco probe in the center. Everything will come up automatically, because machines are designed that way. Chopping has to happen in situ. If you one thing you can take from my presentation, please aim for that. Chopping in situ.
Okay, sir. Thank you, sir.
Thank you, Dr. Rita. Thank you, sir. One more question from Dr. Aparna. Kindly mention the ideal setting for brown cataract.
So this is a very difficult question to answer. So what is ideal for me may not be ideal for you. So I would say one thing, that when you start doing these harder cataracts, have the company person with you, because your method or your technique, the person should be smart enough to judge as to what kind of vacuum are you able to tackle things. The concept is very simple. The basic principle that you have to remember is, harder the cataract, higher is the vacuum. So when you're doing chopping, if you have a grade 5 cataract, I would use a vacuum of around 450 to 500. But if I have a NS2 types, I really don't need that much of vacuum. I just need to hold the nucleus. So 250, 300 is also fine with these things. And as far as the phaco power is concerned, now these technologies keeps changing. So for example, Centurion, if you say now the balance tip has come, so they don't advocate 100% torsional phaco. So in 65% itself, you can do the whole phacoemulsification comparatively. So again, the technologies keep changing. You have to just be abreast about them and modify your technique based on how you are getting the outcome. So I would suggest that in the initial phases, I would actually tell you that when I was in the learning phase, way back in Chennai, 2005, 2006, 2007, immense support was there from J&J team. I actually acknowledge this, because those times we had this signature machine and Sovereign Classic. So everybody was learning actually. They were also learning as to how the machine works. We were also learning. And it was all of doing and learning. So slowly and steadily, we understood that these are the settings which work for chopping. These are the settings which work for quadrant. But believe me, in the same OT, all the surgeons have different settings. So there's nothing called as ideal. You have to work it out for you. Have a person, because J&J team definitely is that way very cooperative. They do come and help you out with your setting. But don't take the standard settings from them. That would be my humble request. So because the moment you give the settings, you try to change your technique based on the setting. But it should be vice versa. You make your technique or how you want to do it and change the setting.
Thank you, sir. Thanks.
Yeah.
So Dr. Sushil has unmuted. Anything, Dr. Sushil, what you want to ask?
Excellent presentation, Dr. And I'm sorry I joined a little late by 5 to 10 minutes and missed the most important part where you were describing the horizontal chop, the way you go about it. Also the horizontal, the in situ, the take-home message that you gave is excellent, and the excellent presentation. Thank you very much. I'll be grateful if you could just review that, I think, for the benefit of the others also. Thank you.
Yeah, sure. So in one simple 2 lines, I'll tell you what is the concept of horizontal chop. Horizontal chop is you control the nucleus. How do you control the nucleus? If it's grade 2, grade 3, you dip your phaco probe inside the nucleus, starting just above the center. Don't start at the center, because the moment you start above the center, you will reach the center. Why the center? Because we all know the center has the thickest lens matter as far as the anatomy is concerned. So you want to reach the centermost point. Moment you have touched that, your vacuum holding capacity comes in. That means how good is your foot pedal control will set in. So you have to practice that vacuum in step 2 to hold the nucleus, because that's the time where you don't want phaco. So you should hold it and then gradually slide your phaco chopper. Initially, you can keep the tip horizontally, and as you slide it towards the equator, just make it vertically, and then hold the nucleus, feel it. Keep your phaco probe still. You are still in the vacuum. Don't move your this hand. You just move your this hand. So the moment you move this hand, as it comes closer, you just go in the opposite direction. So what happens is the crack initiates and separates. Initiation, separation. This is very useful in grade 2, grade 3, but you are dealing with grade 4. The phaco probe also has to move towards the chopper. So what is happening is you are basically doing 2-dimensional cutting from chopper as well as the phaco probe. And the moment they come close, you have to separate. So that is the basic concept. So the whole crux of horizontal chopping is your foot pedal to control. We have good foot pedal control. It's very easy. Very easy.
Thank you. Excellently conceived and very nicely presented. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, Dr. Sushil. Question from Dr. Pranjal. I'd be requesting Dr. Pranjal to unmute and ask.
So, it's my son, Dr. Sachin, wrongly label name of my as a Pranjal. But sir, my question is, I'm using Alcon Laureate, and I started I was doing stop and shop. But the situation is that after sculpting, my probe is not holding the nucleus. I have changed the settings. I've asked the Alcon people. I think the settings problem or the machine problem is there, but what can be the possibilities why it's not holding the piece?
Okay, so if not holding the piece, basically the concept is the vacuum is not getting built up. So what you need to tell when you are doing the chopping activity, you ask your theater assistant to see the value that comes on the screen. So when you are at the top level of the holding, the vacuum should be the maximum vacuum that you have preset in the machine. If that is not coming, then there is a problem with the machine. You got my point? So the vacuum is the most important. If your vacuum is not getting built up, you will not be able to chop. So it's basically related to your holding ability. So you should basically power is not important in chopping. You understand this point? Power is only for you to get into the nucleus. After that, it's just the play of your vacuum. So if you are not able to hold it, there are two reasons why you're not able to hold it. One, the machine is not achieving enough vacuum that you have preset for the machine. Second, the problem is that the moment you are initiating the chop, your foot pedal to control is not happening. So the vacuum gets lost in that, and the moment the vacuum gets lost, you have lost the game. So that comes with practice. Believe me, it will come. There's no problem at all. But you have to consciously remind that I have to keep it in vacuum in step 2. So vacuum has to be very important. So your hand stability and your foot stability, these are two important points which should come together and give you the direct hands of the chop comfortably.
Thank you, Dr. Pandal. Thank you, sir. So one more question in the chat box from Dr. De. So I'd be requesting Dr. De to unmute and ask if possible. Sir, while grade 2 cataract chopping, straight tip or bend tip will work better.
Okay, so if you are starting Phacochopping, I would suggest a straight tip to learn with. Okay, because it gives a better holdability. There's no doubt about that. A lot of like Laureate, a lot of the entry-level machines have straight tip. Even with the advanced machines, you have an option of doing with straight tip. Especially with J&J, you can do with straight tip also. 30 degrees is fine. But for efficiency in dense cataract and ability to use torsional phacoemulsification or elliptical phacoemulsification from signature, you need to ultimately get adjusted to a bend tip. And it is a transition. Let me be very clear about it, that if you are learning, it's a good idea to learn with the bend tip itself, because for us it was a transition from a straight tip to a bend tip, and it took a little while for us to get adjusted to. But if you're still in the learning phase, my advice would be to go in for a bend tip only, because it becomes easier for you to kind of adopt to the newer forms of energy systems that keep happening.
Yeah. Thank you, sir. Dr. Aparna, Dr. Neha, and Dr. Rita is thanking you for your wonderful presentation, sir.
Thank you. Thank you.
Just one question, one clarification.
Yeah, please.
May I?
Please.
This is regarding once we have made the pies. Then do you make any changes in your parameters when you are reaching those pies? No.
Yes.
Same parameters which you were using.
No. I do make changes. So basically, the concept is once you have done your chopping, you are going to do emulsification. Now, what you want during emulsification, you want a little higher flow rate, because these pieces should come to you faster. So you basically increase the aspiration flow rate, and you can increase a little bit of phaco power also, because the efficiency of phacoemulsification has to improve, because you're going to emulsify those pieces. So the principle is that you need the pieces to come fast to your probe, and you need to increase the phaco power. In what way you will increase the phaco power will depend on what machine you are using. But yes, you have to increase the parameters. You have to increase the parameters. Yes.
Thank you again. Thank you.
Thank you, Dr. Sushil. Because of the paucity of time, we may take one or two more questions if Dr. Sagar allow us to do the same.
I have no problem. I think I overshot my time. I overshot my time.
So I'd be requesting participating doctors, you can ask. So we may take few more questions. So you can unmute and ask. So message from Dr. Manjula. She's also praising you for wonderful presentation.
my advice to all of you is to start doing chopping, because it's the most wonderful technique for phaco. All sorts of cataracts you can comfortably tackle with this. The nucleus management part goes out of your head the moment you get a good technique which gives you consistent results. You are not at all worried about that. So keep doing it. It's just a matter of practice and applying the right principles. I think that's the most thing. And you can read one or two books. My take would be that obviously reading book is important, but ultimately it's the practice which will make things easy for you.
Right. So one doctor is probably asking question. Doctors, you can unmute. Yes, doctor, please.
Hi, sir. Good evening.
Good evening.
Aninder here, sir. Aninder here, sir.
I'm not able to hear.
Aninder here, sir.
Aninder, acha. Hi.
Okay.
Hi.
It's as always a pleasure to see your surgeries, because I have learned every bit of my surgical steps and modifications from your surgical videos only and your tips. But I have a peculiar doubt, like when you are handling a leathery cataract, when the base plate is not just getting separated, instead of you are getting a floret type of thing, how to handle in that situation?
Yeah. So basically, when you approach these kind of cataracts, you are not aiming for a complete division at all. I just informed that when I was showing my black cataract, so I don't aim for a complete transaction at all. I am basically trying to get pies done. Half crack is fine. And then you individually deal with these pies, because these pies, you can get rid of 70% of these pies by just emulsifying from the top. And at the end, what will remain is a very small portion of the central cataract along with the bases of these pies. And believe me, that is how it should be done, because that is very easy to handle rather than putting so much of force to separate the fibers. Leathery fibers are not going to give way easily. Whatever you do, even if you make a huge trench and divide into two, you are still left with huge two heminuclei to handle. And those two heminuclei, again cracking them, and once you create sharp edge, that sharp edge itself has a potential to cause PCR rent. So in these cataracts, make sure that you don't make sharp edges, because that itself, you realize that you are doing everything fine, and suddenly you see a rent, and that rent has happened nothing from one of the sharp pieces, piercing the posterior capsule. So my take on this hard cataract is don't aim for complete transaction. You basically keep dividing the nucleus till the point you can start eating each pie easily. And it works. Only thing is you have to be patient with dealing with these cases. It's normal cases will take about 2 to 3, about 2 minutes for your nucleus management. This might take about 7, 8, 10 minutes. Doesn't matter. The time doesn't matter. It should be a controlled way of doing it. Absolutely controlled. Things should be under control, in your control.
Okay, sir.
Yeah.
Thank you, Dr. Aninder. One more question, sir. We'll take this as a last question from Dr. Aparna.
Sure.
So when beginners end up making a crater instead of chopping successfully, how to manage next?
Yeah. So this is a very common scenario. There are two ways of dealing with this. The safest way, I would say, that since you have already made the crater, so you have almost debulked the nucleus. So you can just do a hydrodissection if your rexis is adequate size. If your rexis is small, don't do that. If your rexis is adequate, you can just prolapse half part into the out of the bag. Don't prolapse the whole bowl out of the bag. Once you have the half ball out of the bag, put viscoelastic below it, and then make it tilt and then aspirate it off. The other way, which a lot of seniors will do, experienced doctors will do, is that they will catch hold of the edge of the crater, and using just vacuum, they will bring it out. But that needs a little experience, I would say, time for that to happen. And these are the only two ways. If somebody wants to add, I just saw Dr. Sagar Bhargava here. He can also chip in. Actually, he's a very experienced surgeon. Dr. Sagar is there.
No. I am listening to you. You go ahead, Sagar.
Please. If you want to say anything, you can please add. Soft cataract. I think that these are the two main ways you can deal with it. But crater is the difficult thing, and I think the safest way is then prolapse a part of that crater into over the bag and deal with it.
Okay, sir.
Right. Yeah. Yeah.
Sagar, sorry, I want to add one thing regarding the chop.
Please.
Quite often I have
Please.
seen because of the mismatch. I actually missed the part of your presentation. So because of the mismatch between the sleeve and the blades which we are using 2.2, sometimes they're not 2.2. And if the sleeve is very tightly fitting, then also we can lose the hold and the chop can fail. So in this situation, slightly increase the wound slightly.
Absolutely.
So that
Absolutely.
the
This point we did mention at the start of the presentation that one
Okay,
has
okay,
to be
okay.
very sure that we are not dealing with the watertight wound at the frequency stage, because that will compromise the irrigation and a surge will happen. Yeah, surge will be happening. Yeah, that was very important point. Very important point. Especially at the start.
Thank you, Dr. Sagar. Thank you, Dr. Sogato, for your valuable input.
Sagar, I hope you are all right now. Recovering
I'm
well.
fine. I'm fine. I'm fine. So everything is okay, under control. And thank you.
Thanks.
Thank you, everybody.
Yes, sir. Any takeaway message from your side, sir?
My message I kept giving throughout my presentation is to just chop, in situ chop, in situ chop. Life will be very easy.
Thank you, sir.
Anything.
Thank you, sir. So with this, we come to an end of our today's session. On behalf of Phacochop, I'd like to thank our speaker, Dr. Sagar, for an excellent session and sharing his expertise and experience with us. Also, I'd like to thank our participating doctors for their valuable presence. Thank you, everyone. Thank you for your presence. Thank you, sir.
Thank you all. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.